When we talked about the burns initiative initially, we brought it home from the regional quality meeting, and we really brought the initiative back to a local level. What does DISC do? What do we do differently? What type of cases do we do? And how does it apply to us and our patients?
In the OR, the surgeon has the ultimate responsibility for the outcome. Preventing burns is a complete team effort. People don't think burns are going to happen, but inadvertent use of things or inattention to details and following that method every time, they will happen.
Our operating team huddles twice a day, and in the morning, part of that morning huddle, they do discuss burn risk with any of the patients that they're operating on that day. We already had a handover sheet with checks and balances between the pre-op nurse, the patient, and the OR nurse when she came to pick up the patient.
The electrocautery is designed to create a burn. It has to be used carefully so it's done appropriately, and inadvertent use can create a problem. Any metal that comes in contact with the table will create an area that grounds instead of the pad and will create a bad burn.
So jewelry is a big thing, and it's more and more a big thing these days because people have a lot of piercings. With the discussion of the burns initiative and pre-op particularly, it's a confidential conversation with the patient to make sure that they really do disclose any sort of piercings that they do have and to make sure that they remove them.
The case should start with the surgeon talking to the anesthesiologist. Is it okay to start? Is everything ready? And the team should confirm.
Definitely the prep does increase the patient's risk, and it's really related to pooling of any alcohol-based preps.
During our cases, every time an alcohol prep is used, we time a full 3 minutes to make sure it's had time to evaporate before placing the drapes and potentially capturing explosive vapors.
When we're operating on anyone above the xiphoid process, you definitely want some sort of seal between the surgical site where you're prepping and the use of cautery and the oxygen. We don't drape before the prep's dry. Somebody on the team will speak up. The drapes can become soaked with alcohol and increase the patient's risk of fire.
The combination of alcohol preps that have not been allowed to air or dry properly mixed with oxygen can be the recipe for disaster. Every time out, I have the nurse speak the settings the cautery is set on to make sure it's not set too high. It'll create an initial burn when I turn it on the first time. The audible alarm is important for the entire team to know that the bovie is turned on and needs to be in the proper position.
The bovie unit is always holstered, and the bipolar is placed on the Mayo at the back of the field. The cords are always untangled, they're loose, and the tips are always kept clean with no char, so there's no chance of it sort of like breaking off or flaking and dropping onto the drape when it's hot.
Think of the electrocautery as only on and off in your hand, in the wound, in the patient for its proper use. Any other activation can cause a burn.
The scrub tech role, our scrub techs do a couple of things. One is that when they actually have a blue towel on their back table that's soaking in case there is a fire. They holster the cautery units so they are not going to be accidentally let off lying on the patient. They also pull back any sores or burrs during an orthopedic case back onto the back table rather than leave them lying on the patient where they could be hot coming out.
Hot metal objects can cause a burn to the patient. If you use an autoclave for anything, especially a piece of metal, a retractor, an arm that may hold things in place, make sure it's been cooled fully before placing it in proximity to the patient or using it. The metal can retain a lot of heat out of the autoclave and cause a severe deep burn.
So anesthesia, we like to have them involved in all of our initiatives because they do encourage the surgeons and the surgical team to have some sort of ownership around any sort of initiative or safety program. The physicians really lead the way in the burns initiative in the OR. It's their operating room and they're ultimately responsible.
When it comes to burns, good is not good enough. We have to eliminate them.